Some of you may have noticed that we're starting to use the nomenclature of SLAM-F7 as opposed to CS1, which is what we used to call the target for elotuzumab. And there's some scientific reasons why that switch has been made, really for the sake of clarity more than anything else. So let's talk a little bit about why antibodies are so important. And before we get into the nomenclature idea. So this is my sort of simple definition of therapy. We have old school therapy, which is like the Model T, with alkylators, corticosteroids, and Dr. Ludwig's favorite drug, doxorubicin. And these are sort of the old-fashioned drugs, as it were. We've now evolved to an era where drugs like lenalidomide and thalidomide and bortezomib represent the novel agents, and those are sort of like the 1960 Mustangs now, which I think is important. They're important parts of our history, but we're even starting to move beyond those now into what I think are the really cool-looking cars, and I'm not really a car guy, so hopefully those of you who are not offended by the choices of images that I put up there. But I think antibodies are really going to represent the next real big wave in what's exciting in myeloma therapy, and they're going to allow us to really change the landscape, and as I mentioned yesterday, I think ultimately get us to a higher fraction of patients who are cured with myeloma. So why do we really need antibodies as we think about treating patients with myeloma? Well, we know that drugs that we have, like proteasome inhibitors and IMiDs, have improved progression-free and overall survival. I think every talk that we saw yesterday demonstrated that improvement. There is a whole concept of mutation-driven, not plasma cell biology-based approaches that I think are important. But one of the real challenges we've had in myeloma is that baseline immune function is simply not normal. And by not having normal ADCC functioning, that has limited the efficacy of monoclonals up until now. And so what I think is really exciting and important is the concept that antibodies represent a risk-agnostic approach to treatment. They're not necessarily dependent on P53 in order to kill cells, and this whole idea of risk agnostic is, I think, really important as we move forward with trying to make inroads in the high-risk, highly proliferative subsets of disease patients with myeloma, where the benefit of all these new drugs may have been less clear over time. So this is sort of a bit of a landscape of antibodies that are out there. You can see lots of different antibodies targeting both the plasma cell as well as areas within the microenvironment. And what we're going to focus on in the next few moments is elotuzumab, focusing again on SLAM-F7. So it is not a different antibody, it's not a different target, it is exactly the same target, it's just a new name. And the idea is that CS1 is used for a number of different, to describe a number of different targets, and so there's some ambiguity when you use the term CS1, when you refer to it as the target for elotuzumab. SLAM-F7 is actually a little bit more scientifically accepted international definition for the target for elotuzumab. And again, the idea that it targets both the NK cell and the myeloma cell, I think, is really important because we know that elotuzumab can bind SLAM-F7 on the surface of an NK cell and increase NK cell activity. And that is an important part in terms of mechanism of how this works. So what do we know from the early data with elotuzumab? Well, this was a single-agent trial where the majority of patients developed some level of stable disease, but there were no real true objective responses seen in that single-agent phase 1 clinical trial. And we had sort of almost gotten to the point where we thought, oh boy, here we go, another monoclonal that really should work, that by itself is not giving us the kind of efficacy and data that we wanted to see. And then there were some very nice data done by Mahdev Dapkar, demonstrating the idea that lenalidomide can enhance NK cell function and it can enhance NK cell number. And this concept here started to raise the idea that perhaps that defect was an important part of why monoclonals to date had failed. Monoclonals that are purely dependent on NK cell function and activity maybe didn't have the NK cell burden to really be effective. And so the idea that Mahdev really demonstrated was that you could use lenalidomide to enhance that efficacy, and it was known that elotuzumab was dependent on NK cells in order to be effective. based on that and additional data from Ken Anderson's lab suggesting that IMiDs plus monoclonals, and this is a monoclonal that we don't really use anymore, but the concept of combining an IMiD with a monoclonal really began to take hold. And based on that, we then started to look at combining elotuzumab in preclinical models with lenalidomide. And here you can see is some of the preclinical model here, where you can see in the in vivo models using either elotuzumab or lenalidomide is somewhere here. But when you combine the two, you really start to get major impact on NK, based on its NK cell function and effect. You really start to reduce the total burden of disease over time. That then gave rise to an initial phase 1 study where elotuzumab was combined with Lendex, and there was no dose-limiting toxicity seen, going up to a dose of 20 milligrams per kilogram, and this led us to a randomized phase 2 trial that I'm going to show you some of the results of in the next few minutes. And in this randomized phase 2 trial, everybody got Lendex and everybody got elotuzumab. The difference was 10 mg per kg versus 20 mg per kg. And the reason this is an important question is antibodies, as we know, there's no reason to think about dosing to an MTD, to just keep pushing the dose over time. In fact, we had heard a very nice talk yesterday in one of the lymphoma biology talks that really suggested that going to higher doses with monoclonals may actually make things worse in certain situations, especially where you're dependent on effector cell function to really be important. So the idea of perhaps being able to go to a lower dose of elotuzumab was an important step forward, again, similar to what we did with ixazomib in the last talk, where we looked at once weekly and twice weekly dosing. Patients were treated until progression in the relapsed phase. And these are the patients. You can see a total of 98 patients were enrolled in the phase 1, phase 2 trial in aggregate. You can see the fractions of patients that had different types of treatment over time. And again, the phase 2 portion was really the randomized part of 10 versus 20. If you start to look at adverse events here, there's really nothing that you see here that is not unexpected, with the exception of infusion reactions. And infusion reactions was a bit of a learning curve early on, but once we got past the phase 1 and we figured out what the pre-medication schema was, the incidence of infusion reactions almost completely went away or was very manageable with just the first dose. So again, these are important things to note. The rest of the AEs that you see are probably not dissimilar from what you'd expect with lenalidomide and dexamethasone. So again, a pretty well-tolerated induction regimen, or relapse regimen. So if you start to look at differences in response rate, 92% was the response rate in the phase 2 portion of those 36 patients. If you look at the 20 mg per kg, the response rate was actually slightly lower. And if you look in aggregate, the overall response rate for the phase 2 portion was 84%. So pretty good when you think about response rates for an antibody in combination with lenalidomide and dexamethasone. And this gave us clues that perhaps the 10 mg per kg was the dose to move forward with in phase 3 trials. And actually, fortunately, that is the dose that was used to move forward with in phase 3 trials. Now, response rates are nice, but what about progression-free survival? This is PFS for the group that got 20 mg per kg in blue and 10 mg per kg in red. And as you can see, 33 months was the median PFS for the 10 mg per kg. Compare that with an expected PFS of 11 from MM009, looking at Lendex in the early relapse setting, and it was shorter in the 20 mg per kg group of only 18 months. So this whole idea of dose escalation and pushing to MTD, again, I think is an important thing to think about as we consider monoclonals that are dependent on effector function cell to really be effective as we move forward. So again, I think this is a very active combination. I have a number of patients whose only main toxicity is that they're tired of coming to see me in the clinic to get their elotuzumab infusions. That's not a bad problem to have. And again, 33 months is almost unheard of for PFS, certainly in a phase 2 study for patients in a relapsed myeloma setting. So what other trials are out there? Well, again, the monotherapy we talked about, there is a trial combining with bortezomib that showed an overall response rate of about 48%, with a median PFS of about 9.5 months. And then again, the trials that we talked about here, looking at either looking at a phase 1 experience or the phase 2 that I mentioned earlier on. So the trials that are ongoing or about to complete enrollment, this is Eloquent 2. This has completed enrollment, I think about 18 months ago, and we're in the follow-up phase at this point. Eloquent-1, which is a newly diagnosed trial looking at either Lendex or Lendex plus elotuzumab, is about to complete enrollment, and this forms the second of the phase 3 trials, hopefully getting us approval of a monoclonal antibody in myeloma. And then additional trials ongoing is a phase 2 trial of bortezomib dex plus or minus elo. There is a high-risk trial being done through SWOG, looking at Lendex plus bortezomib plus elotuzumab with delayed transplantation in just high-risk patients in SWOG. Elotuzumab plus Thaldex is being done in Europe. Elotuzumab in high-risk smoldering, I think, just completed enrollment as well. This is an important study. And then a renal impairment study looking at Lendex plus elotuzumab as well, just to give us additional options for patients who present with renal dysfunction. And I think I'll stop there.